Good morning, and thank you so much for joining the Care First family of difference makers today. My name is Destiny Simone Ramjan, and I am proud to serve as Care First Vice President of Community Health and Social Impact. Care First's not-for-profit mission is to provide affordable, accessible, quality health care for our members, while also thinking deeply about the communities we serve. We aim to transform the healthcare experience with and for our members, our communities, both here in the region and around the nation. As a public health sociologist, I often say that your zip code is a better predictor of your health than your genetic code. And we know that zip codes in Black and Brown neighborhoods have higher rates of poverty, unemployment, poor housing, toxic environmental exposure, as well as less access to quality medical care, each of which contributes to poor overall health. Importantly, these outcomes are not just rooted in personal responsibility, but rather a history of discrimination in housing, finance, education, and so many aspects of daily life. Health disparities are not an accident. They truly are a result of inequality that continues to shape both our health and our economy, which is why today we're so excited to talk with our expert panelists as they discuss the impact of access and equity on the populations that they serve. We hope that by today's close, you will glean actionable insights to better address the social determinants of health in your communities. So we have three objectives for today. We'll learn more about the critical role that accessible language plays in advancing health equity. We'll discuss best practices for helping diverse communities access the care they need when they need it. And finally, we'll talk about successful communication strategies and outreach for overcoming COVID vaccine hesitancy. Before introducing our panelists, I'd like to share a little bit about the work that Care First is doing to address vaccine equity in Maryland, D.C., and Northern Virginia. In February, we launched our Better Together campaign to educate and encourage people to get vaccinated against COVID-19 when they can by supporting public health officials' work to achieve target vaccination rates. As of June 2021, over 4,000 Care First employees and over 750 organizations have taken that Better Together pledge, representing over $1.2 million in contributions, directly impacting community partners working to further our region's vaccination efforts. Our commitment to equity extends beyond equitable vaccine distribution. On April 20th, the Blue Cross Blue Shield Association announced its National Health Equity Strategy to confront the nation's crisis in racial health disparities. This is a bold and transformative strategy designed to change the trajectory of health disparities by collecting data to measure disparities, by scaling effective programs, by working with providers to improve outcomes and address unconscious bias, and by leaning into community partnerships at the community level. We hope that these actions will also influence policy decisions, both at the state and federal level. Without further ado, today I'm joined by three subject matter experts working to drive equity in vaccinations and healthcare access in the National Capital Area. Our first panelist is Dr. Tuesday Cook, an advanced laparoscopic and bariatric surgeon, and is an obesity medicine board certified diplomat of the American Board of Obesity Medicine. She currently sits on multiple local, state, and national, as well as international committees focused on decreasing health disparities for people of African descent, as well as Latinx communities. Dr. Cook has served as a physician panelist in town hall discussions with the White House COVID-19 Health Equity Task Force, and she's also been featured nationally on syndicated radio shows and social media platforms as a proponent of increased access to care and health equity, discussing the social and political determinants of health in the in minority communities. Dr. Cook? Today, we're also joined by David Stive, who serves as the Language Access Director at IUTA. In that capacity, David helps to lead a program that trains interpreters educates legal and victim service providers on language access best practices, advocates for enforcement and amendment of local and federal language access laws, and uses public funding to arrange for free interpretation and translation services for approximately 100 nonprofits throughout the Washington, D.C. metro area. Thanks for joining us, David. Finally, Dr. Jamshed Upal, PhD, serves as the Interim Executive Director and is representing the MCC Medical Clinic, a project of the Muslim Community Center in Maryland. The clinic's mission is to provide compassionate and high-quality medical care to the uninsured and indigent adult residents of the community. With his long association with the clinic, Dr. Upal brings valuable insights for extending healthcare services to vulnerable populations. He's also been instrumental in steering the clinic throughout the current challenges arising from COVID-19. He's currently engaged in outreach initiatives to overcome vaccine hesitancy among at-risk populations. Panelists, we are so fortunate to have each of you join us today. I couldn't be more thrilled. Before starting, I'd like our audience to know that each panelist will give a brief introduction and overview of how their work has been impacted by the COVID-19 pandemic. Dr. Cook, we'd love to start with you.
Good morning, everyone, and thank you for that wonderful introduction, Dr. Ramjan. Thank you for inviting me to be a participant in this very important and timely discussion regarding access and health equity amongst the Black and Brown Latinx populations. It's quite important, so I'm glad to be able to participate. I am a laparoscopic and bariatric surgeon, fellowship trained, who has been in Maryland for more than the past 20 years. And I have practiced in both Prince George's and Montgomery counties, doing bariatric surgery, weight loss surgery, as well as general surgery, colon cancer resections, gastric cancer resections, breast cancer excisions, et cetera, for essentially Black and Brown patients for decades. And I absolutely enjoy it. And I think that I will continue to do so, and now have added a third major goal to my repertoire, which is to ensure that we have the same access to COVID-19 vaccinations and healthcare as everyone else in the country.
Thank you so much, Dr. Cook. We're happy to have you. David?
Thank you so much to Care First for hosting today's event and for all of your work with the Better Together campaign and the National Health Equity Strategy. It's really a pleasure to be here today. So I work at a nonprofit called AYUDA, and we serve immigrants in DC, Maryland, and Virginia. We actually have offices in all three of those jurisdictions. We have lawyers who assist clients with immigration matters and family law matters, and we also have a social services team that offers case management and therapy. And then finally, we have a language access program, and that's the program that I work for. And the language access program, what we do is we take professional interpreters and we train them on how to work in legal services and in victim services. And then those specially trained interpreters, they're professional interpreters, so we pay them to go to 100 different nonprofits in the area as needed. We apply for grant funding in order to be able to run the program and pay the interpreters. And we end up serving about 100 nonprofits, mainly working in legal and social services. So part of what we do is train the interpreters to make sure that they're able to do this important work. And then part of what we're doing is just reducing barriers, making sure that for the nonprofit sector, legal services and social services, they have what they need in order to serve everyone equitably. And we also provide document translations for written documents, and also provide them with sort of on-demand telephonic interpretation through a third-party service. So we try to offer as many different options as possible to make sure that they can overcome language barriers whenever that's needed. And I think we've learned a lot from the pandemic. Some of it was things we already knew, but it was a good reminder, that not all of our clients have access to the internet or are comfortable with Zoom. Email doesn't always work for every client. Sometimes the text message or a phone call would be better. So there have been a lot of lessons learned from the pandemic, and I'm excited to talk about all of the lessons learned today. Thank you.
Thanks so much, David. And Dr. Cook and I just learned about your excellence with training in Zoom, so we're really happy to have you here today. Let's have Dr. Upal introduce yourself next. Thank you for being here.
Yes, thank you, Destiny. My name is Jamshed Upal, and as introduced, I work with the Muslim Community Center's medical clinic. The clinic was established in 2003, almost 18 years ago. And our main focus is the uninsured and underinsured population of the county and the surrounding areas. Over those 18 years, we have had over 100,000 patient encounters. And we are so proud to have served them. Pre-COVID volume, the throughput was almost 18,000 patient visits every year. So we were doing quite a bit of volume. Our main area that we draw our patients from is Montgomery County, PG County, DC, and also some further north areas. Our patients are coming from, varied races, backgrounds, ethnicities. Our basic aim is to, or goal is to serve them without, regard to race, origin, ethnicity, and so on and so forth. We draw on a lot of volunteers, but also we have providers who are full-time MDs and nurse providers. Our population is mostly new immigrants and many undocumented immigrants also, undocumented as well. And that poses very challenging, situation for us in terms of the languages. They speak all kind of languages, and the culture they bring, they are not accustomed to the institutions and the dealing with the government. So they're looking for a clinic which can relate to them in a culturally friendly and linguistically friendly manner. So that's our main sort of main attractor. But I'm so happy to be here, to be part of this town hall meeting. And I'm thankful to CareFirst for having arranged this. This is a timely and very important subject, and I look forward to hearing from all of you.
Excellent. Thank you each for those outstanding backgrounds and introductions. I know that our audience feels the same way that I do, the rich tapestry and diversity of the populations you serve, but also the work that you're doing to ensure equity and access is essential. So thank you again from CareFirst for being here. We'll get into the meat of today's discussion with our first question posed to you, Dr. Cook. We're here to talk about equity and access, and certainly the last 16 months have transformed the way that we all approach that work. How has your approach to access changed since March 2020?
That's an excellent question, and I'm sure it applies to everyone here and every person taking care of people in the world at this point. But as you know, I'm a bariatric surgeon, and so I care for people who suffer from obesity. And I do general surgery as well, but the majority of my patients suffer from obesity and its comorbid diseases, things like type 2 diabetes, hypertension, high cholesterol, sleep apnea, frequent lung diseases, et cetera. And so my patients were the ones who were really at highest risk for death from COVID-19. And so that placed me in a very unique position in terms of wanting to make sure that my patients not only had their weight loss surgery that would improve their life expectancy, et cetera, but that they understood the risk that it posed to them in terms of needing to be safe, et cetera. Obesity worsens the outcomes from COVID-19. Having obesity increases severe illness, even people who are overweight. It's a 3-time increased risk of hospitalization due to COVID-19 infection. They have increased risk of being ventilated, and they're harder to ventilate because of their decreased lung capacity. Both obesity is linked to decreased immune function. So my patient population was a very specific risk population. And obesity affects us differently. It disproportionately impacts racial and ethnic minority groups, right? So non-Latinx Black adults had the highest prevalence of self-reported obesity in 2019, followed by Latinx adults. So that was 40% of them self-reported obesity. Latinx adults reported at 34%, and non-Latinx white adults reported at 30%. So you see the big disparities in terms of obesity across the spectrum of ethnicity, and so when it came to modifying how I practiced, one of the things that I did that was quite helpful, and David Stieb alluded to this, was increasing telehealth. And so that in and of itself increased access in ways that, we had tried for years to be proponents of, but this crisis, this pandemic, made it such that we were able to do this in a forcible manner. And so it forced people who weren't sure whether or not we should to say, well, we need to, if we want to decrease the pandemic. And so my patients who are in rural areas, who couldn't come to see me, my patients who are in urban areas, who couldn't get time off from work, didn't have childcare, had to travel on 2 or 3 buses and trains to get to me, were able to have visits. I could see new patients who couldn't come during work, but couldn't come afterwards because they take care of the children or they had to go to a second job. So people who had multiple modes of employment just to make ends meet could see me, during their lunch break at work. So telehealth really increased access to patients who otherwise would have been denied the access that they needed. And we did that not only for the safety of the office, but the safety of the patients, and we were able to see new patients. We were able to see post-operative patients who wouldn't have to travel to come in after their surgery. I could just see them and talk to them in that way. We were able to give seminars about weight loss surgery, obesity. It is recognized as a disease by the American Medical Association, their comorbidities, how to stay safe during COVID-19 because of their increased risk. We were able to do virtual support groups, virtual nutrition visits, all the things that go along with trying to decrease the risk of patients who, had the highest chance of dying, with their comorbid illnesses, their medical problems. And so telehealth was a big thing. Phone conversations are great, but being able to talk to a patient, see them, examine them, online was a big deal. And I could reach so many more patients than I could pre-pandemic. That was one way I was able to change it. Another way, even though I was able to change, was even though I've been going to Capitol Hill and going to Annapolis and trying to lobby for both physicians and patients, but I was able to lobby even more, working with Montgomery County Medical Society and working with MedChi, which is our state medical association. We were able to do virtual legislative sessions, write additional bills, because as you see more patients and you have more interaction with people who you understand a little bit more about their barriers, things like not having access to broadband, that's a real thing. Some people in Montgomery County and in Prince George's County are doing better than others. And so it seems kind of normal to us to have internet access or a smartphone, but not everybody has that. And so we need broadband if we are to continue to expand access to care for all the patients who need it, but need to be able to get to it, even if they can't travel to it. And in the world that we live in now, my daughter went to school virtually for a year and 3 months, right? So these are things that we need to give to everyone should have access to that. And that's going to increase healthcare access. So to be able to do legislation and to visit, the government, the bodies, the people that we elected into power, to be able to visit them and talk to them about the things that people who are on the ground, soldiers who have boots on the ground, need in order to take care of the people who voted them in. Those are the things that I was able to change a little bit during the pandemic in terms of my practice. Yeah.
Excellent. And thank you so much for that comprehensive response. It was really vividly describing some of the pre-pandemic barriers to access to care that we were forced to contend with directly and head on. I want to fast forward to 2021 and ask you about the COVID vaccine and a little bit more about how you have reached clients who have been hesitant to receive the vaccine.
So that's also an excellent question. You know, I could go as far back as the creation of the vaginal speculum, but I'm not going to go that far. I'm going to stay more in the present. You know, Black and brown people have been the victims, for lack of a better word, of medical apartheid since time immemorial. You know, pain is not being controlled. You know, we don't have pain. We can work without meals. Those kinds of things are historical. And like I said, I'll try to stay in the present, but there are reasons why people have vaccine hesitancy. There are reasons why people mistrust the healthcare system. And those reasons exist today. It's not just historical. It is present. And, you know, I have to talk to my colleagues as well to make sure that we're all aware of things that are going on right now. And so when we address patients who are worried about getting the vaccine, we have to make sure that we validate their feelings that are historically correct. You know, again, my patients who are not all obese, but even my own patients, because Hispanic and non-Hispanic or Latinx and non-Latinx Black adults have a higher prevalence of obesity and they're more likely to suffer from worse outcomes. You know, and they don't have broad opportunities for economic and physical and emotional health. And even those inequities have, you know, increased the risk of them getting sick. And then to now have a vaccine available to them and them not take it, you know, it kind of hurts us to our core. And so things I've done have been small things, like talking to the patients one-on-one, giving them a little handout saying, hey, what's your email address? Let me forward you a YouTube video from the CDC or from World Health Organization if you trust them more, or in your language, like David Stipe sent links that have all different languages. Let me just send you something. You can look at it at home. When you come next time, let's just talk about it. You know, if you have questions, just call me, you know, leave a message and we'll talk about it. So small scale things like talking to each patient one-on-one, talking to their family members, you know, who come with them so that the whole family can get vaccinated if they, you know, ask their questions, try to debunk myths. So the one-on-one patient thing is very helpful. Talking to my community is very helpful, my family members, you know. And before I did any of that, because as a Black person in the United States, I too was a bit worried. I attended those 8-hour FDA sessions. I went to the different webinars that Pfizer and the creators of the Moderna vaccine put on to inform us that the actual, you know, PhDs were there. I wanted to have every ounce of information I could have. I read studies about mRNA virus vaccine creation from decades ago to make sure that I had information before I decided that, yes, I prayed. You know, everyone doesn't pray, but I prayed because I needed guidance in order to actually accept this vaccine. And so I understand how my patients feel. I let my patients know I am you. You know, and I'm a physician, well-trained, multiple degrees. But to live in this country is to have a bit of hesitation. So I understand where they're coming from. So in addition to getting all the information and then getting it myself, because I can never tell a patient to get something that I didn't get, I then send that information out to them at a level that they can understand. Because we also have to understand that we have patients that are at different levels: second grade education, high school education, college educated. You know, you want to make sure that we meet the patients at where they are. And so from a one-on-one patient level to a community level and family level to a broad town hall. So I've done several town halls with University of Maryland, with White House COVID-19, you know, Health Equity Task Force, with MedChi, with whoever I could get on and talk to people as a representative for people who look like us, because we can trust us. You know, there are multiple studies that show concordance between, well, how patients feel when there's concordance between the patient and their caretaker. We know that there are actual research studies about the decreased mortality of newborns when they are taking care of a physician that is of their ethnic background, of their race. So we know how patients feel. And so hearing it from someone who looks like you and actually felt like you, to say, okay, here's what we need to do, and debunking myths, you know, causing infertility, they're putting a microchip, My friends, I could just take ginger. If I just stay healthy, I won't get it, and I tell them, your mom took care of you and she made sure you got your vaccines before you went to school. Now it's your turn. It's your turn to take care of yourself. No one can force you, but here's the real information for you to make an informed decision. It really is about informed decision, an educated decision. And the decision you make is ultimately your own. So I've done it for New York because I grew up in Brooklyn for a good bit of my life when I came from Trinidad. And so, I've done town halls virtually in New York, so that everybody that I know, again, people I grew up with, my old teachers, friends, people who lived in my old neighborhood, can be aware and have information as opposed to having myths, and so then make a good decision about what they want to do.
Excellent, excellent. David, Dr. Cook outlined some really clear barriers and the approaches that she's taken, particularly as it relates to language. And I saw you nodding vigorously, so I want to stay on that question for just a moment to hear from you. How have you or IUTA reached clients who are hesitant to receive the COVID-19 vaccine?
Thank you. Yeah, I was nodding along because I think that, so much of what Dr. Cook said really resonates. One of the changes I think we've seen is that, these little boxes are becoming very familiar to all of us, right? So video and sort of online presence is increasing. And I think that for a lot of the client community, that needs to extend to social media, right? Something where they might be able to find it on their phone if they have a smartphone in their language. Because I think the client communities that we serve have varying levels of literacy, right? Not everybody is gonna want to receive information in a written form. Sometimes it's better to receive it as a video, particularly if it's in your language, if you speak a language other than English. Or if you're part of the deaf community and your primary language is American Sign Language, then you may not rely on written language. I mean, written English is very different language than American Sign Language. So to have a video in American Sign Language is really important. So I think I was also nodding my head about sort of virtual support groups. That's also really important, is that just reaching people and bringing people together has been possible in a virtual setting where you don't have to worry about the barriers that are involved with travel or childcare, or any number of things that might have kept you from going to a different physical location. We serve about 100 nonprofits. Some of those nonprofits have held information sessions online about the vaccine and trying to answer people's questions and educate them about it. And what we've done, in our capacity at Language Access Program, is make sure that those virtual meetings have interpretation. So, one of the things that we've had to quickly come up to speed on is remote simultaneous interpretation. And, I don't want to get too far into the weeds, but just so everyone knows, you could have a group meeting on Zoom, sort of whether it's an information session or a support group, and you could conduct that meeting in multiple languages. The person facilitating the meeting can be speaking one language, and some of the people in the meeting could be using another language through a different channel. Like Zoom, for example, has different channels. So you could choose the Spanish channel and there would be an interpreter doing simultaneous interpretation to make sure that the group is accessible to everyone who's attending.
Thank you so much for that. I want to shift gears a little bit, Dr. Upal, to ask a question of you. What do you see as the biggest barriers to access for healthcare and social services within your client community and within the organization?
The main fact remains that the populations that we serve are indigent. They are poor, they don't have the resources, they are financially handicapped. On the other hand, they also lack these non-financial resources to actually seek medical help and medical care. For example, somebody has to take time off from the job to actually come to the clinic. So that's a big barrier. Somebody has to, sometimes people have to get their daughters or sons to bring them to the clinic. and then son or daughter will have to take time off. Our population is also not technically as proficient as otherwise. So there is a technology gap as well. So these are non-financial barriers. Financial, of course, cost is involved. We do try to help whatever we can, but ultimately somebody has to, foot the bill and somebody has to pay. And we do charge a little, very nominal sort of a copay. But even then, people coming from far off, long distances, they come and they just raise their hands where we don't have any money. So we do take care of them. We don't let anybody go without being taken care of. But that is a very big barrier. Um, uh, we talk about the financial, but non-financial aspects are equally important. So we try to, for example, provide transportation. We try to somehow, we know, of course, the telehealth has been a boom. We uh, we were caught by surprise by this COVID, so was everybody else, and it hit us unprepared. So we had to improvise. A lot of the processes and a lot of practices had to be modified. So one of the shift that took place was, creating an infrastructure for conducting telehealth visits. And we are very thankful to CareFirst for providing us with much needed grant. So we could put up the infrastructure. We could also have a navigator, a nurse navigator who was, totally focused on this aspect. So the patients needed a lot of help, a lot of hand holding, where to click, how to connect, and so on and so forth. And that now the patients are more sort of accustomed to that. And to our surprise, many patients have found that this was much better than actually taking a trip to the clinic. And also, our top priority was to make sure that we are safe, our community is safe, our providers and patients remain safe. So we had to reinvent our processes, keeping social distancing. And telehealth has been, a big lifesaver from that. And we have been actually, as Dr. Cook was mentioning, we have been actually been able to expand our sort of services and to better take care of that. Um, I think I strayed away from your question. What was the question again?
No, I think you hit the nail on the head. A part of what we were talking about was about barriers to access. And thank you for acknowledging that the grant. I want to acknowledge our Maryland grants team, including Hosanna Aswamins and Sandra Bengpong. I remember when they reviewed that application from MCC and really described it being of the highest quality to support pivoting of access to services. So want to stay on the topic of pivoting for a little moment, David, and move to you. How have you been able to pivot your services to address the varying and often complex needs of your populations?
Yeah, this has certainly been 15 months of pivoting. That there's no doubt about that. On the one hand, our mission stayed the same, which was we wanted to make sure that whenever legal and social services organizations were meeting with clients, that language was not a barrier. But the mechanics of doing that has changed quite a bit, right? Because everyone has moved, for a while there, it was almost 100% remote, right? Everyone was doing things remotely in situations where they usually would have met in person. So you usually would have had an interpreter in the room, conveying messages between the two people in the room. And all of that moved to virtual. Now, we went where the need was and where the clients were, and that meant different things for different clients. Some clients we're not going to be able to easily join a video call, right? And so it would be on the phone, and the interpreter would join through the phone. Some clients would be, they might already have WhatsApp on their phone, and maybe that's the best platform to use rather than an online, virtual setting. Some clients could do video calls and preferred that. So we really tried to make sure that we could offer interpretation in any of those settings. And of course, that was a big job, because not only did we have to pivot the language access program, but all of the interpreters, the field of interpretation had to pivot. Interpreters had to learn, they had to get headsets and microphones and learn how to use the video platforms and, sort of set up a home office. And everything changed kind of overnight. But the community of interpreters was extremely resilient, and they've been amazing about, serving the needs as they exist. The other way that we pivoted as a program was we had an interpreter training. We had a 3 or 4 day interpreter training scheduled for the summer of 2020, and we were able to pivot to have that online. So that was, in large part to our interpreter trainers. They were really resilient and just moved the curriculum to online teaching. And the other thing I would mention is the video that I mentioned earlier, video services. Some of the nonprofits that we serve, they're doing information sessions online that they probably would have done in person before. They're doing an info session online, but they have a separate channel in another language. We're providing the simultaneous interpreter. And what they record is sort of the visual of the online presentation, but the audio in Amharic. And then they put on their Facebook page a recording of this information session in Amharic. And the community can access that in their language without leaving their home, right? With hopefully using a smartphone or a computer. So there have been, in so many ways, the landscape has changed. We've also seen, even government agencies and court systems are putting videos on their website about operations. Now that the court is partially closed or fully closed because of the pandemic, they are putting videos in multiple languages, including sign language, on their website, so that the information is accessible to the public. And then, obviously, the other way in which our program has pivoted is having to work from home. Like, our program has been working from home for quite some time, and that was obviously an adjustment. But yeah, I think those are the major pivots that happened.
That's excellent, David. Thank you for that perspective. I'm going to stay there for a moment. Many of us who are in the sort of healthcare and upstream sort of work are thinking now about how transformative the pandemic has been, but also sort of how we go back to a new normal, so to speak, right? And this concept of new normal is sort of, what are we going to retain from the lessons learned, and what do we sort of need to shift? So my question to you, and Dr. Upal, I want you to get prepped. I'm going to ask you that same question is, what do you think stays the same, right? How will you continue to incorporate the lessons learned from the pandemic, even as we continue to return to a new normal? So Dave, first to you, and then to, okay, go. Sorry, David, I was going to say with
you. Want me to go first?
Dr. Upal.
That's fine, yeah.
I can
Yep.
go first.
Go for it.
I think for sure, technology is going to be a big part of it. We've already seen how telehealth visit has become an integrated part of the whole scene. And this can also come to our help in terms of, for example, reaching desperate, different background, different ethnicities, different languages, just as David was explaining. I think it's wonderful to know that technology exists that can allow us to reach out to these different populations. And it's going to become more important, not only in terms of we may have another, virus just on the horizon, or another I hope not, but that is quite possible that we may have another pandemic right behind it. But so we need to be prepared. That means we need to keep up to date with the technology. And in next year, new technologies will, of course, have come up, but we need to be at the cutting edge of the technology so we can always use that technology to face any challenges that may occur. The other thing is that we need to keep on, a good tab on what our population is, what our clientele is, what patients we serve, and we learn quite a bit from their needs. Of course, there's a general need for medical services, dental services, specialty services, but also under the current circumstances, the utmost need is to, provide them with the right information about vaccinations, about its side effects, and overcome this hesitancy. So we have to go beyond this. We do have the 5C model that experts talk about, but on top of those, that the conventional model, the main thing which needs to be really attended to is to overcome this distrust of the government agencies, distrust of for example, people are less likely to listen to what CDC says, but more likely to listen to what Dr. Cook may say to her own patients. And so person to person, that connection is utterly important. The psychological factors become utterly, very, very important. The other aspect beyond the conventional model is the fact that social context makes a big difference. Especially populations which are socially isolated, they are more likely to, be hesitant in seeking vaccines. And the population that we serve is certainly suffering from a lot of social isolation. For example, new immigrants or undocumented people, they are actually, that's a main problem. So once they become socially isolated, you have to approach them in a culturally friendly, ethnically friendly, and linguistically friendly manner. And from, that's where, clinic like us can play a big role, because we are connected with what you may call the hard pockets or deep pockets, which may indicate certain resistance. So I will stop and here and pass on.
Excellent.
Yeah.
Dr. Upal, I want to add a follow-up question to that, which is that many of our audience members today are really eager to work with the populations you serve, both to eliminate social barriers, but also create greater access to healthcare. What do you think is the one thing our audience needs to know about the population you serve at MCC?
Yeah, we started to work on this vaccine hesitancy much earlier. In January, we held a town hall meeting followed by a couple of other meetings. We also had a webinar in Amharic language, for example, and then we planned on many other webinars in different languages. But we found out quickly that, the most effective way to convey our message is on a one-to-one, on a personal basis. So our current strategy is that our providers are going to continuously engage in a person-to-person, and either through telehealth or communication, or through person-to-person, and talk to them. The main obstacle is people want to know, what are the side effects? What does this do to me? Is it going to change my DNA, and so on and so forth? So for that, a personal assurance by a person who they can trust, maybe this is a provider, maybe this is a religious leader, anybody who, maybe it's, a neighbor, or, from their community. So that makes a huge difference rather than, doing a very sort of a generic kind of a webinar. Or so providing literature in languages, providing services like David mentioned in different languages, and having them, connect to people who look like them, who speak them, who talk like them. And that is, I think, the key. Because more or less, we have in Montgomery County, for example, 67% of the population or more is now vaccinated. But in our population, we are behind 5 to 6%. So we see that, we see disparities across races, we see disparities across age as well. But interestingly, what we don't see is a disparity across religion. That is, among our, that's a surprising thing. Our analysis show that, as a matter of fact, we are a Muslim community center, but our Muslim population is at par with the county, vaccination rate, but other religions are behind, much behind that. So I think what is lacking is the right information and communicating them this information in a friendly way. Thank you.
Excellent, thank you. We have about 10 minutes left, so this is going to be my very last question. I'm going to pose it first to you, Dr. Upal, and then we'll go to you, David. Dr. Upal, you're talking about a very kind of, I think, significant issue here when it comes to vaccine hesitancy, which is trust. I know our audience is eager to learn more about where they can find more information from trusted sources. So I want to close by asking you, what is your go-to trusted source for information about improving equity and access for underserved populations?
Of course, it depends upon, who is seeking that information. If we are, talking about providers, I think they are already well informed, but places like CDC websites, that's of course the place to go. And that website is so rich, and they have all kinds of material for all levels, for people who are thinking about or who are at the edge or who are at the margin. They have a lot of material in various languages, for example, also in simple terms. And I find all those materials very convenient, very useful. As I said, we started to get in this very early. We tried various ways. We, started to produce our own sort of clips, video clips, and so on and so forth in different languages. But then we found out that there's always there's a lot of material already available, and all you have to do is to put them in one place. In terms of video clips, YouTube clips, in various languages, there's a lot of material available. And some of them we have made it available on our website as well. So we can direct our patients to our website. If you want to listen to somebody talking in Bangla, here's the website. If you want to listen to somebody talking in, for example, Baha or, Hindi or for any other language, those videos are already there. Excellent productions, experts talk. But they're not going to seek them themselves. Somebody has to point them to these places. The good news is that what I understand is not, we don't have many vaccine deniers. We, of course, there are people who are totally opposed to any kind of vaccines. So we have people who are on the margin, who are trying to make up their mind, and they need a little nudge, little encouragement to, bring them in the camp. but we need to do that urgently and vigorously.
Excellent. Well, may we all be nudgers. Thank you, Dr. Upal. David, we're going to turn it over to you. Again, kind of on the topic of trust, what is your one go-to source, your trusted source of information for improving equity and access for underserved populations?
So I really appreciated a lot of what Dr. Upal said and sort of the framework that he used. One of the things that is so important is to be prepared, because when disaster strikes, it's too late to start thinking about a language access plan. You need to have a language access plan in place before the next pandemic, before the next hurricane or whatever it may be. And so one resource I wanted to just mention is the Asian Pacific Institute on Gender-Based Violence has a way for organizations to create a language access plan in advance. The Casa de Esperanza also has guides on how to create a language access plan. Ayuda also has a guide for legal services nonprofits, but I think it's transferable to other nonprofits as well. So that's one resource. And then with regard to the vaccine, yes, I agree. The Centers for Disease Control and Prevention have some excellent materials. They have a whole channel on their YouTube channel. They have a whole section on American Sign Language for deaf community members. And then they also have written materials in many different written languages. And in general, for organizations that are serving the community, it's so important to provide videos or documents in other languages, because not only does it convey the information, right? If my primary language is Chinese, I'm not going to understand something in English. So not only does it convey the information, but it also lets the community know that if they come to you for help, they will get that help in their language, right? If I see that you're posting a bunch of stuff in Amharic, then I know that I can go to you and you won't turn me away because I speak Amharic. Now, the important thing is that you actually do the follow through, right? That when someone comes in speaking Amharic, you are prepared to serve them. So you want to make sure to think through, and that's why you need the language access plan in advance, I think. And the other thing Dr. Upal mentioned was know who your population is. I think that's really important. Who are the communities that you're serving? You can go on lep.gov, which is it's a website maintained by the Department of Justice. LEP stands for Limited English Proficient. But lep.gov has a bunch of tools where you can look in your geography where you serve, what are the languages spoken, just so you have a sense for whether you're really reaching the whole community or only part of it. And then the last thing I would mention that Dr. Upal mentioned is technology, and that Dr. Cook mentioned, that we've all mentioned is technology. And I would just say one word of caution, and that is make sure that as you move into those realms of technology, that they're accessible, regardless of people's ability to tap into the internet or computer, and with regard to language, that it's not just a technology solution for English speakers, it's a technology solution for everyone.
Excellent. Thank you so much, David. My fellow Brooklyn sister, my Trini sister, Dr. Cook, I'm going to turn it over to you for the last word here. 60 seconds so that we can end on time today. What is your one go-to trusted source for information about improving equity and access for underserved populations?
So since I have 60 seconds, I'll make it quick, but that means I'll talk extra fast. I'm not going to reiterate what David Stibe and Dr. Upal discussed, because I think the CDC is an excellent website. I think they've done a good job, in fact, a great job of putting it together and making sure that everyone who seeks it can get some information accessible to them. So I think that's a big or an important way to access information. Speak to the people you trust. Trust and transparency. Transparency lends trust. Your healthcare provider, your religious leaders. I think there are many ways that we can get that information out there, but the CDC is a big resource for us. I will also say that, even just going to local people. So we've trained barbershops, workers in barbershops and salons to be certified healthcare workers. And so they are trained on the information, and they can give that information out to their clients, who then can decide to get vaccinated right there in the salon, or right there in the shop on a Saturday morning when they go to get their hair done. And they are, these people are trained by us. And even President Biden has now collaborated with University of Maryland School of Public Health, the Center for Health Equity, to give a $1,000 grant for participating barber salons and shops so that they get taught, they get trained, they have pamphlets, they have screens that show correct scientific, real information as opposed to urban myths and legends, so that people can be educated. And once they decide, they can get their vaccine and they can be safe for not only themselves, but for their children who can't be vaccinated, and for the elderly who have their medical problems, who have been vaccinated, but still, so that they can be safe for their communities. And so I think reaching out to different sources, in addition to the CDC, but to people who you trust that are right there in your neighborhood, I think that's important. And I want to make sure that I end on a note of, we need to treat obesity. We know neighborhood, build environments, access to healthy food. All these things are important. The way that we get to these things, to change those social and political determinants of health, is to make sure to write your legislators. Make sure you write emails, you write letters. They probably have blocked me, but they won't block you because they can't block all of us. Write. Go online. Go to who's my legislator and put your zip code in. And it'll bring up a whole list from your council person to your governor and state senator to everyone. And you write them emails. We need grocery stores. We need parks. We need safe places to exercise. So that you have access. Pharmacies, even. We need pharmacies. That's where they sent the vaccine first. And some places don't have pharmacies, no matter where you go. So I think it's important that we
could not agree more. Thank you so much, Dr. Cook, David, Dr. Upal. We are ending almost on time. Your passion, your subject matter expertise, and your challenge to us to think deeply about trust, about not going back to what we had before the pandemic, but also being transformative and harassing our legislators in our personal capacities. Thank you to all our attendees for your thoughtful engagement. At the close of this, you'll receive a brief survey. We hope that we appreciate your feedback. We hope to continue these conversations. Thank you on behalf of our Care First Difference Maker family. Have a wonderful day. Bye-bye.
Thank you.
Thank you for having me.
Thank you.
Wonderful discussion.